A rumor is going around that 9 of the Nashville patients are on ECMO. It is unverified, and 9 does not fit the 4 we know were harmed. I'm Dr. Harvey Jenkins, MD PhD, retired orthopedic spine surgeon, pain management physician, and biochemist. So let us do the useful thing with a rumor. Let us use it to learn what ECMO actually is. ECMO, extracorporeal membrane oxygenation. Extracorporeal means outside the body. Membrane oxygenation means adding oxygen across an artificial membrane. Put simply, it is a machine that does the work of your lungs, and sometimes your heart, from outside your chest. Here is how it works. A tube pulls dark, oxygen-poor blood out of a large vein. A pump pushes it through an artificial lung that adds oxygen and removes carbon dioxide. Then bright, oxygen-rich blood flows back in. It is a longer-lasting cousin of the heart-lung machine from open-heart surgery, running for days in intensive care. There are 2 kinds, and this is the difference that matters. If the blood returns to a vein, it supports the lungs only, and we call it VV. If it returns to an artery, it supports the heart and lungs together, and we call it VA. Lungs, or heart and lungs. Hold that thought. ECMO began in newborns back in the 1970s and grew into a rescue for the sickest lungs and hearts. Severe pneumonia, the lung failure called ARDS, cardiogenic shock, even some cardiac arrests. But understand what it is. It is a bridge, not a cure. It buys time for something else to heal. It does not fix the underlying injury. It is not on every corner. ECMO lives at large, well-resourced centers, recognized by a body called ELSO, staffed around the clock. Smaller hospitals stabilize and transfer, and mobile teams can even start ECMO at an outside hospital and bring the patient back. Notably, the Nashville patient was moved to a top-tier ECMO center, so the capability was there, which is a separate question from whether it was needed. For most of its life, few people had heard of ECMO. Then COVID filled hospitals with exactly the lung failure it treats, and its use surged worldwide. New programs opened, and the word entered everyday speech. It also taught hard lessons about choosing the patients most likely to benefit. And no one person runs it. It takes intensive care doctors, cardiac surgeons who place the tubes. It also taught hard lessons about choosing the patients most likely to benefit. Plus specially trained nurses and respiratory therapists at the bedside every minute. It is a team sport. So would ECMO even apply here? This is the key, and almost no one explains it. There are only 2 reasons to need ECMO. The lungs cannot oxygenate the blood even with help, or the heart cannot pump. Now here is the crucial part. If the only problem is that paralyzed muscles cannot move air, that is a ventilator's job, not ECMO's. A ventilator pushes air in whether or not the diaphragm works, and a ventilator is exactly what was reported for the Nashville patient. And the anatomy makes ECMO even less likely for breathing here. The nerves that drive the diaphragm leave the cord high in the neck, at C3, 4, and 5. The injury reported was at the chest, well below that, so the diaphragm is usually spared. For ECMO to truly be needed, either the lungs themselves would have failed, or potassium reached the bloodstream and struck the heart, the same way it stops a heart in a lethal injection. So even if ECMO were used for any patient here, it would be a bridge through a heart or lung emergency, not a treatment for the paralysis. Nothing about ECMO undoes a spinal cord injury. And the rumor that started us? 9 does not fit 4, and the care reported was a ventilator. Take the lesson, set the rumor down. The full breakdown is on the site.